And let us start the last day's morning session. And most respectfully, I would like to invite as chairperson, Dr. Jolly Rohatgi to the dais. Ma'am, please take your seat. And again, respectfully, I invite our co-chairperson, Dr. Rohit Saxena, sir, to take the dais. And I'm accompanied by our moderator, Dr. Jayanti Kashyap. And I am your co-convener, Dr. Soni Sanha from the LSC, Associate Professor at the Patna Medical College. And as I know that we have got two authors already present here, so I think I can hand it over to Dr. Jayanti for calling the speakers.
Thank you so much, ma'am. A very warm good morning to all of you, though it's not very warm here. So, Dr. Ambasta Anita is here? No. Okay. Okay. Dr. Kirandeep Kaur? No. Dr. Abhishek Kumar? Okay. Yeah, please come forward. Topic.
Yeah, good morning everyone. My topic for today's presentation is transient smartphone blindness. So transient smartphone blindness it's a recent phenomenon characterized by acute painless transient vision loss associated with smartphone usage while lying down in the dark. The increase in screen time and lack of change in focal length leads to many ocular problems, and transient smartphone blindness is just one among them. So approval was obtained from DEC and study was conducted in accordance with the tenets of the Declaration of Helsinki. In this study, which was conducted among our college students, each of the 454 residents of the college hostel have experienced a sudden episode of transient blindness after prolonged screen time, especially during night, at least once. So most incidences occurred while going to the washroom and resolve after reflex closure of eyes for a few moments. All students have reported this to be uniocular. So what is the physiology during adaptation? There's alteration in pupil size, there's switchover between rods and cones, there's bleaching or regeneration of the photopigment layer, and there is feedback from horizontal cells to control the responsiveness of photoreceptors. So this is just a depiction of a student looking at his smartphone with one eye closed. So symptoms occur specifically at night while in recumbent position immediately after turning off a smartphone screen at which they had been looking. The affected eye was contralateral to the side to which the patient was lying and resolved within minutes without leaving any residual blindness. So it occurs due to the temporary discrepancy in bleaching of the photopigment and ultimate light adaptation between the fellow retina. Probably the reason why sailors would keep one eye patched for off-deck visualization when they go inside the deck, and other eye would be light adapted for on-deck visualization. So the differential diagnosis, it must be distinguished from other causes of acute transient vision loss, especially thromboembolic diseases such as amaurosis fugax. Age is an important differential factor. It is seen generally in young. While non-arthritic anterior ischemic optic neuropathy may cause acute painless unilateral vision loss, but symptoms would be expected to persist. Additionally, in multiple sclerosis, patients would have some kind of color desaturation and abnormal MRI findings. So it has been suggested that patients should use only smartphones in well-lit rooms, and to assure that neither eye is occluded, should be conversely advised against smartphone usage in dark sittings in order to prevent the recurrence. And incidentally, this would also be expected to improve the patient's sleep hygiene. Uh, Correct diagnosis of TSB is imperative, as incorrect diagnosis may put the patients at risk. If misdiagnosed as thromboembolic etiology, patients may be unnecessarily started on anticoagulation, which can pose obvious bleeding risk to the patient. If incorrectly treated as multiple sclerosis, the patient may be inappropriately started on disease-modifying therapies, which pose significant side effects as well as financial burden. In addition to the field of ophthalmology, recognition of this entity may also be relevant to other physicians, such as the physicians of the family medicine, internal and emergency medicine. Ultimately, this phenomenon emphasizes the importance of thorough history taking in ophthalmology and in the field of medicine. So take home messages, the incidence of transient smartphone blindness will surely but definitely increase in coming times. There is a need to create awareness among middle-aged and middle-aged population, especially the youth, to understand what it is and how it occurs, and there is need to stay calm. Screen watching should preferably be done in a well-lit room, and an awareness should be created among general population about working in a well-lit space and potential morbidities it can avoid. These are my references. That would be all. Thank you.
Abhishek, you haven't worked up any cases. This is essentially a review of literature, right?
Sir, it was just like we just conducted like a small questionnaire in our college hostel, sir.
Yes, but you didn't give us too many details about that questionnaire. Na? That is the study that you should present. You know? This is essentially reviewing about smartphone blindness. So while you've done a good job and made aware everybody about the importance, but a little details about the questionnaire, what was the questionnaire and how many responded. So those are what a free paper and a study would ideally, expect us to. Or else he could have even compiled the literature and said that how many publications are there, how many cases are there, have been reported, and what are their features. So anything, so a free paper essentially, talks about research. So it need not necessarily be original research. It could just be a case, or it could just be a, compilation of data. But it should be have a scientific basis. So that's the essential thing.
And the topic is really very nice. Yeah. It is day-to-day practice. It will be very important. But the thing is that from this talk we have not come to know anything. Whether what is the duration of that exposure, and whether it is one eye, both eyes, and how much time it took to reverse back. So all that is important. Topic is really good.
In fact, yeah, I think now that you have worked on this for a subsequent paper or something, so you analyze
They
it,
had
I think
experienced it or not experienced it, just a name and just
maybe
one
you
or two
should
questions.
see a few more questions and do it on this. It's a very important topic and an interesting topic. I think maybe next time in the next meeting or anywhere, you can think of having a more appropriate structured questionnaire and kind of get more analysis. There should be a little analysis to a research so that we can come to some conclusion based on what you have done. I think it's very nice. You picked up a very interesting topic, and all the best.
Thank you.
I think we concur with the other two judges, and there's not much left to discuss. I think call the next person. Hi, yes, I've told.
So she'll not be presenting.
She won't be there. Dragon is there.
Next speaker.
So next Dr. Ragib Tauhid is here. He will be presenting on necessity of neuroimaging in neuro-ophthalmology, consensus and disagreement about its urgency.
I don't know, he may not have been informed. So हम छोड़ देते हैं. Maybe we'll carry forward those marks from yesterday's session.
Good morning, everyone. My topic is necessity of neuroimaging in neuro-ophthalmologic cases, consensus and disagreement. There is no financial interest in any of the product or technique mentioned or discussed in the study. Neuro-ophthalmology shares high risk of life-threatening pathology than in other ophthalmic subspecialties. Neuro-ophthalmic signs are commonly the presenting features of intracranial space occupying lesions, and hence neuroimaging is frequently required to rule out serious intracranial disease and sometimes to rule in. However, there are significant medico-legal consequences to missed or delayed diagnosis when patients with serious neurological conditions present first to the ophthalmology. Consequently, Personal experiences or expert opinion guide the decision regarding neuroimaging necessity, but at the same time, health economic factors highly influence the urgency of neuroimaging. As a result, imaging for neuro-ophthalmic conditions may occur less urgently than the requesting clinicians would like. Thus, urgency of neuroimaging in day-to-day practice in the health service, either being private practitioner or under government cover, is therefore determined by pragmatic balance between clinical judgment and pressure on the imaging services. The aim of the study was to get expert opinion of how urgently to request neuroimaging for neuro-ophthalmological clinical scenarios. Neuro-ophthalmologists were approached with list of 35 different neuro-ophthalmological clinical scenarios generally presented in the IOPD and asked to state how urgently they would obtain neuroimaging. There were 4 responses options. First, emergency, that is within 2 days. Urgent, within 1 week. Observation, after 1 month or at 1 month. And the fourth one was no need. Consensus was set at a prior level of 70% agreement. These are the list of the 35 clinical scenarios. The result was 18 out of 35 scenarios made the criterion for consensus. 3 of these were for emergency imaging. Of these 3, 2 were for presentation of third nerve palsy, namely both scenarios stating pupil involvement but in a younger patient. The third one was one scenario for which there was consensus on emergency imaging was downbeat nystagmus in 60 years old with 6 months history of oscillation. Consensus was reached for urgent imaging, that is within 1 week, for 5 scenarios. These were bilateral optic disc swelling with the recent onset headache in 25-year-old, asymptomatic bilateral optic disc swelling with drusen and reduced visual function in a 40-year-old, asymptomatic bitemporal hemianopias picked up incidentally by optician in a healthy 40-year-old, acute painful isolated Horner in a 40-year-old, horizontal jerk nystagmus with 6 months history of oscillations in 60-year-old. Consensus for the response category of observation was reached for 6 scenarios. These were asymptomatic bilateral optic disc swelling with drusen and normal visual function in 40-year-old, asymptomatic unilateral optic atrophy with mildly reduced visual function in a 50-year-old, picked up incidentally by opticians, suspected unilateral functional visual loss in a 20-year-old, unexplained bilateral central scotoma in 25-year-old, bilateral 6 nerve palsy in 65-year-old diabetic, sudden onset unilateral 4th nerve palsy in a healthy 40-year-old with no long-standing features and no head trauma. For the response no need, there were 4 scenarios, and these were blepharospasm in a 40-year-old. Second one was a spasm of the near reflex in a 40-year-old, suspected bilateral tobacco alcohol or nutritional amblyopia in a 40-year-old alcoholic, acute unilateral typical non-arthritic AION in a 65-year-old with hypertension. The conclusion was neuro-ophthalmologists differ on urgency of neuroimaging, with consensus for some neuro-ophthalmological cases and disagreement for many. To determine timing of the neuroimaging, furthermore prospective or retrospective studies need to be done. This attempt at assessing areas of consensus and disagreement regarding the urgency of new imaging in a neuro-ophthalmology is crucial for future decision-making regarding neuro-ophthalmological cases. The principal weakness of this study is that it reports neuro-ophthalmologists' stated practice, which may be influenced by the recall bias. Audit of the actual practice shall be more accurate, but could be logistically difficult across so many hospitals. In addition, there have been many neuro-ophthalmic scenarios that were not addressed in the survey, and also the simplification of the scenarios is not genuinely reflective of real patients, where multiple additional clinical and the psychological factors play a part. Nevertheless, it could serve as a valid qualitative reflection of expert opinion in a controversial area where an adequate evidence base is lacking. These are my references. Thank you.
It's a good presentation.
Thank you.
First of all, I just want to know that you have not kept some fact. You have just named the disease.
Yes, ma'am.
Though no details are there.
Yes, ma'am.
Like patient's history and presentation may do a lot with the decision of the neuro-ophthalmologist.
Yes, ma'am. That was, I mentioned that was the demerit of my study. Yes, ma'am.
How did you come to the list of
So I searched over many journals like PubMed, Future, like that.
And are there any previous such
Yes, sir.
so there are
Very
consensus
few. I found on the net, ma'am, sir.
so
But
how are your results comparable to what others, or what is in published literature as
sir,
practice?
yes, sir. Exactly, I found a lot of differences between India and whatever the research is done abroad. So I think there are lots of confusions regarding the cases in India because most of the setups are in the government hospitals. So it depends on the radiological services.
It's very good that you've done this. You could do a little more details in your analysis, like
sir.
duration, number of people who agree. So there is agreement, but how much, how many? Plus, there could be a timing duration when you ask them that how urgently. So they want it immediately within a couple of days, or are there any other signpost which they look for? So of course that increases the subjectivity, but I think it's a very interesting piece of work. I mean, it's very nice. A little more details may actually help in really giving us the clinical scenario in India, which, as you said, is very different from the West and the recommendations of the standard of care according to the Western literature. Thank you.
Thank you.
Thank you for your wonderful presentation. Any more speakers have come? Dr. Amrita Pradhan is around? Any?
Kirandeep for both are not. So
Dr.
in the meantime,
Kirandeep.
we can have Dr. Venkatesh is here.
Yes.
He can make his presentation. He has to also, we have to score him in that separate sheet. इसकी एक ही copy है क्या?